Two questions. I think I'll be able to respond partially, and I think Scholar will also be able to support on that. So I agree with you, Francis, that digitization is the way to go. And why am I saying this? One of the biggest problems that we have had in the facilities with regard to reviewing cases is lack of the tools, either the notification forms or the review forms. So sometimes they are there, sometimes they are not there, sometimes they do photocopy, and sometimes we don't even have a photocopier in the facility. So as you are saying, if we had these at the touch of the button, with having a system whereby all these documents are available, where people can download, use them, or even use them directly on the system. I think like KHIS, I'm not very sure whether you have we have such a tool where we can just put the information directly. I think that would be useful. All I know is that digitization has been one of the strategies that the Division of Reproductive Maternal Newborn Health is undertaking. And I mentioned the digitization of the tool, the standards MNH standards assessment tool. I think that is one of the tools that is being undertaken for digitization. But I agree that all these other tools needs to be available at the health facility. Maybe Scholar will be able to explain how far they are doing on that. Yes, again, the issue of the point of care ultrasound, and it's good that Veronica has clarified that actually these equipment are being supplied in facilities, which is good, because one of the problems that was identified in the CMD is challenges with delayed diagnosis, and then after diagnosis taking too long to make treatment. And again, one of the recommendations was having these diagnostic tools and services being available in maternity. So the challenges are there, as you have mentioned, in terms of accessing the service when a cost is put. And why is this cost being put? Because of the cost of the films. I don't know whether they are called films, to produce the image, and whether a policy can be made on this. I think Scholar is going to be the one perhaps to respond on this, because as long as we have a fee, then of course access is a problem. But I believe these are some of decisions that can also be made at the county level and at the facility level, because if we continue waiting for the national level to make some of these policies, then it takes too long and our mothers will still be missing the serving. The skill gap is still there, and I believe it's not, we have reached a point whereby it's not just the department, what do you call it, the radiography department that has to do this ultrasound. The midwives should actually now be trained, the clinical medicine, to be able to do these tests, because it is point of care testing. It should not be that the mother is being sent somewhere. So I don't know whether a Scholar would want maybe to add something. I may not be very good at what the ministry is doing.
Okay, thank you, Onesmus. I may not have a very conclusive answer for that, but for digitization, that is where we are headed. Through the Department of Informatics in the ministry, we are moving to digitize all our information. So I don't know how long it's going to take, but it is something that is ongoing. It's in progress. And we hope that in the future, we'll have all our information digitized, and we'll be picking the information from there. About the review forms are already in the system, so I think it's just a matter of having the connection, the internet connection. You can still do it directly into the system. Though we decide to use the review forms and then allow the sub-county or the HRIO to go and upload later, but it is provided for in the system that you can upload that information as you discuss. Is it, Kerich? Yeah, it's there. And then the other question on what? On ultrasound. We are doing all that we can possibly do as a division. Remember, there are how many, if you want to involve the midwives and the radiographers, these people have to agree on inaitwa task sharing or task shifting. And that is where now the problem may be, But it is not like we will stop trying. We will continue trying until a time where we will comfortably have a midwife doing those ultrasounds by the bedside. Yeah, okay, 2 more questions for Nelly, and then we'll see if we'll do another one question round at the end. So please just hold your question. Just hold. Now I'm taking questions for Nelly. Anyone for Nelly? You remember Nelly? Oh, but anything, relax.
Thank you. Thank you. Thank you so much, Madam Moderator. I was just thinking as you were presenting, in Kenya right now we are looking at increased facility delivery. Skilled delivery is at 89%. Health facility delivery is at 82%. In terms of ANC attendance, again, it's not about attendance. The demand is there. Very high uptake of ANC. What could be the problem? Because a lot of those components, if we have such high access to healthcare services, then why is it, what is happening? Is it the second D or the third D? Where are we failing in terms of identifying danger signs, in terms of responding, intervening on time? And I really feel also another component that is also cross-cutting based on the CMD interventions is one thing that I was keen to hear is the introduction or product introduction, especially some of the essential commodities like carbetocin, you know, where we are talking about PPH being the lead killer of these women. Where are we moving so slowly in such interventions? Another component is health financing. Health financing is something we are not talking about, but it embodies everything that we do. For example, resources will always be limited. Access to these diagnostics will always be limited. But if we can maximize on health financing mechanisms, how are we able to think about sustainability in the long term and also strengthen quality of care? Take you.
Your question was for who? For all of them. So decide who is going to take that. Okay, question for Nelly. Okay.
First of all, just to say thank you so much, Nelly, for the research. As part of the methodology, you indicated that you looked at the 126 out of the 252 deaths that are related to the CSS that had been done in 2014. I was just doing some brain gymnastics, wondering why 2014, why not 2018? Because we are looking at 0 deaths. That is where we are moving to. How is the trend currently? Are we likely to get there? Because a figure of 5%, that is quite alarming. Thank you.
Okay, one more question for Nelly. You got it. You got the question. One more question for Nelly.
Thank you, Moderator, and thank you, Dr. Nelly, for the presentation on the risk factors. On the recommendations, you mentioned that the mothers need to be referred early and they should be adequately resuscitated. It isn't clear what adequate is in terms of resuscitation. And then experienced health providers to do the CS. Again, it is not clear who experienced are or is. Thank you.
Okay, thank you, Janet, for your question. Now to you, Nelly.
Thank you for the questions. So I'll answer some, and then I'll hand over to Professor Charles Sami also to give his input. So the first one is on ANC visits, and you correctly put it that ANC visit attendance is very high. Even when you look at KHIS, it's really high. But the challenge is not whether they are coming for the ANC visits or not. We actually came to realize that it's the quality of services that they get. So they will come for ANC visit, but when you ask them what actually happened during the ANC visit, they may not even, tell you what they learned or what they were told or what was done. And there are so many challenges to the same. I currently work, I can say, in primary healthcare at the sub-county level, and most of the challenges we have are commodities. A mother will come and we're not even able to do an ANC profile. So yes, she has come for the visit, but what care have we given? What quality of care have we given that mother? So that's one of the issues that I can answer concerning that. And the second, the Professor Charles will give his input towards the second part of your question. So I'll go directly to the question of the 126 vis-a-vis 252. So it was not the 126 out of 252. 126 were the cases. Those are the maternal deaths. According to the report, the number of deaths were 138, but when we looked at those case notes, some had incomplete data, some did not have adequate data, and we could not use those case notes. So the ones that we actually had to use and were able to go through were 126. So we had to match those cases with controls with a ratio of 1 to 2. We had 252 controls, and so these are deaths that happened in 2014. So the inquiry was done in 2014. That's the data that was used. So it was only prudent to use the same year's data to look for the controls as well. But the report was actually published in 2017. For the recommendations concerning early referral, so early referral, referral is in different stages and different phases. By the time a mother actually gets to a facility, most of the times maybe a level 4 or a level 5 facility, the referral started way down from the community level. So when we are talking of early, it could be from any of those levels. And by the time, sometimes a mother comes to the facility, yes, it's a level 5, but it's how do I put it? It's late. There's nothing much they can do. Yes, they have come to the facility, but they have come at a point where there's no intervention that can be done because the person has come in late. And the delay, we have the 3 delays, right? So there's the first and the second and the third delay. So the delay could have started way at the community level. It could have been referring from the level 3 to the level 4 that took time. And there are so many factors that interplay at that level as well. So the recommendation when you talk about early is at the level where you're at that you get the mother as a healthcare provider, then refer in good time. If you do the blood pressure and you find it's already high, don't start thinking maybe I can buy it another 1 hour or 2 hours. Like we had an incident where a mother had labored in a facility for 24 hours. Surely 24 hours is too long. A decision would have been made maybe by the 3rd hour or the 4th hour, instead of allowing a mother to labor for 24 hours, yet they have a contracted pelvis or something like that. The other one was experienced versus inexperienced healthcare workers, what that meant. So from the study, when we asked who did the CS, so we have interns, we have MOs who are maybe 1 year experience or 2 years. Then we have the senior MOs, someone who has worked in that OBGY department maybe for 4 years, 5 years. Then now we have the registrars for facilities that are privileged to have some, and then now the consultants. So there was that variation per se, that if it is just a facility that only has maybe interns or most of the CSs are done by interns, then you find that the odds ratio was slightly higher compared to the consultants. Yeah. So Prof can.
Yes, thank you. So I think she's responded to the experience and then adequate resuscitation. So you have those patients that arrive in the healthcare facility and you are finding it difficult to even record blood pressure. There's some pulse, blood pressure, you're struggling. I mean, even if you were at an intensive care unit with all the blood transfusion and 10 consultants, you will struggle, with a lot of prayers to come round. So if they're adequately resuscitated before coming, maybe they stand a chance. And then you talked about heat-stable carbetocin. So why don't we have that discussion after my presentation? Because it will, yeah. So, okay.
There's a study that was being done, a pilot that was happening in Pumwani. I think it was some facilities that we just got disseminated results. I mean, the results were disseminated the other day. So it was actually a trial or a pilot study to see if that carbetocin can actually work. And it's something that is in the pipeline to be scaled up to the other facilities.
Okay, thank you. Our panelists, I know there are those who still have questions for them. They're still here with us. I hope, Nelly, you're not going back. You'll not be around. Oh, but Professor will handle your questions. So we'll allow them to go back to their seats and take up our next presentation, session 4. So thank you for answering those questions. They were tough questions. So let's prepare for session 4. Please keep your questions. We'll still ask them. And we will repeat yours also. I know we've not responded to your question. So we'll answer it before we leave. Pamela, ulishika hiyo swali.
Adjust that one. Center. Okay, so I'm well aware that we've lost a lot of time, so hopefully I can save 5 minutes. So we're still looking at some of the data we had collected as part of the Kenyan Confidential Inquiry into Maternal Deaths. And that database has grown now. We have data up till 2018. Am I correct, Pamela? 2019 and 20 still pending to be assessed, but we have from 2014 to 2017. So this, in this sort of secondary data analysis, we just looked at those clinical and health system bottlenecks that could potentially be that we should be aware of if we're going to be able to implement the new WHO recommendations on postpartum hemorrhage. So I just want to say, so I'm going to try and summarize this within 20 minutes. So this has been published in the International Journal of Obstetrics and Gynecology. I'll talk a bit more about that supplement. It was a supplement. And, you know, but this analysis was conducted within this FCDO program. So I'll go through introductions. I'll talk a bit about getting policy into practice. Talk about materials, methods, results, and, you know, some points to discuss. So as I said yesterday, so we still have quite a huge burden of maternal deaths globally. 42% of these deaths are occurring in the least developed countries of the world. Unfortunately, 70% are occurring in sub-Saharan Africa, and 17% are occurring in East Africa, and 3%, which amounts to about over 7,000 women, you know, dying annually in Kenya. So this is a lot, and we should be quite concerned. In 2017, 2018, 2019, WHO published some updated recommendations on postpartum hemorrhage. And this came from very large randomized control trials. One of the big ones was the woman trial, where they trialed the use of tranexamic acid for the treatment of postpartum hemorrhage. Mind you, tranexamic acid has been mentioned previously in PPH guidelines, but not in the way it was recommended to be used. And tranexamic acid has been used for many years as part of trauma treatment for management in general surgery. And then heat-stable carbetocin, which, I mean, as it says, you know, essentially is a form of oxytocin that is heat-stable. But it still has some differences with oxytocin. For example, just one example you should remember, we cannot use heat-stable carbetocin to augment labor, okay? It's not a substitute. It's not for that purpose. Its purpose is for the prevention of postpartum hemorrhage. Our normal oxytocin, so I mentioned that PPH supplement that we did. Now, it's free of charge, you know, International Journal of Obstetrics and Gynecology, supplement on postpartum hemorrhage. So you see lots of papers there. Now, one of the papers, they sampled oxytocin at the point of use from different African countries. Most of the oxytocin that was analyzed, pharmaceutical analysis and chemical analysis, they're found to be essentially blanks. They have very little active ingredient. Well, no wonder you are giving multiple doses. The hemorrhage is not stopping, isn't it? So that's a problem. Now, oxytocin is a drug that is supposed to be kept at a certain temperature from manufacture to use. So most of the time, the oxytocin we have at the point of care to use, they're already denatured. You know, they're not good. So if you break that chain, that cold chain at any point, so you break it from manufacture to central medical stores, and then eventually get to the facility. Then at the facility, we suddenly remember to put it in the refrigerator. It's not going to reverse the chemical process. You know, it's blank already. Anyway, so when these guidelines, after these guidelines were produced, I think through FIGO got a huge grant to try and see how they can work with stakeholders to get these recommendations into practice. Now, this project, this FIGO project worked with ministries of health in Ethiopia, Burkina Faso, Ghana, Liberia, Rwanda, Sierra Leone, South Sudan, and Uganda over 2 years. So essentially what they did, the first step was updating the national essential medicine list with heat-stable carbetocin and tranexamic acid. If you don't update that, it's not going to be procured. There's no procurement. It has to go in there. So the first thing was working with the Ministry of Health to update those essential medicine lists. Once it was updated, then the next thing was to work with all the key stakeholders. So we're talking about people in training institutions, obstetricians, midwives, clinical officers, you know, RH stakeholders, Ministry of Health, to update the clinical guidelines and the protocols, okay? So to update it so that it reflects the new recommendations. Then moving from that, so what we did, so I led this FIGO project, and what we did was to first develop a generic protocol as a template for countries to use. So each country can now adapt it as they like or take what they want to update theirs. So if you go to the FIGO website, you're going to see that generic protocol there. So the next thing was to work with these stakeholders to develop job aids that healthcare workers can use at various levels of care. Some of the job aids they wanted were made as posters that can be deployed through WhatsApp, some posters on the wall, some handbook, you know, digital, you know, different things. So each country had the way they wanted to do it. So they were in the driving seat. All I just did was talk to them about best practice and principles for effective job aids. And they did a really amazing job. Each country did something slightly different, but they understood their context, they understood their people. And we also supported them to lead the dissemination of their now sort of adapted protocol and job aids. So what did we do? How does this link to all of this? So, so during that project, you know, we, cross-sectional survey, talking to all these key stakeholders, what do they think were the challenges to implementing these new WHO recommendations within their setting? And then we wanted to identify bottlenecks to implementing these recommendations using Kenya as a case study. So that data we had from Kenya, we wanted to sort of benchmark it against some of those recommendations. And then, but the way we did that was really performing a standard-based audit using that data based on the Kenyan guidelines. Now, mind you that recently, I think within the past 2 years, Kenya updated their clinical guidelines to include those recommendations from WHO, okay? So that was the basis. So, we developed a conceptual framework, looking at socio-demographic factors, pregnancy-related factors, clinical factors, and organizational factors. So from the Kenyan guidelines, we picked, about 8 standards. And, these were the standards that we audited those records against to see what proportion of those women who had postpartum hemorrhage, had the standards. And then just simple, percentages and all of that to compare, because we should be aiming for 100% to see the level of compliance. So there were 32% of maternal deaths, that had postpartum hemorrhage during this period. So the total number of cases was 2,292. So 728 were died from postpartum hemorrhage. Now, with some sample size calculation, we needed a minimum of 21% of that PPH sample randomly selected, to have significant results. So in terms of the results, let's look at what did we find out talking to these key stakeholders about some of the concerns they have about implementing the new WHO and PPH recommendations. And some of these concerns may be similar to, the concerns that you will have here in Kenya as well. Whereas WHO talks about the use of misoprostol by unskilled healthcare worker for prevention or management of postpartum hemorrhage, because they are not trained to give injections, isn't it? But many countries were uncomfortable about the mention of misoprostol at all, first of all, then let alone unskilled healthcare workers. So that generated a lot of, discussion. And then there was the issue about availability of misoprostol and tranexamic acid at primary healthcare level. Whether we like it or not, women will give birth at primary healthcare level, and they will need care, prevention, prophylaxis for PPH, or if possible, treatment. The thing about tranexamic acid, if you don't use it within 3 hours of your diagnosis, then it's useless. You're not going to get any results. So if the woman gives birth in a primary healthcare facility, she still needs to travel several hours to secondary care or tertiary care. But we say by policy, we don't have tranexamic acid at primary care level. You see, we're shooting ourselves in the foot. It's not going to work. And then there were concerns about the availability of heat-stable carbetocin. So people had this, they gave examples, different countries, that look, if a woman who is rich goes to private care, they have heat-stable carbetocin. The poor woman goes to the government hospital, there's no heat-stable carbetocin. And then there was this notion that heat-stable carbetocin is so expensive and maybe out of the reach of poor families, But that's not the case, interestingly, because I started to do some more investigation. So I belong to several global groups, and I talked to some of the people from Merck, where they manufacture this drug. So their agreement with the WHO is that this drug was going to be available at a very little cost. So somebody's taking off the top part of the cost and available to the countries to stock at a very small price, which should not be more expensive than oxytocin. So price should not be a problem. So that's the information I have. So I'm just surprised where in the sort of supply chain, there's a problem, because I still understand heat-stable carbetocin is not widely available. Then there's lack of awareness and education about heat-stable carbetocin and tranexamic acid amongst healthcare workers. But this was something this project was going to address anyway. And then there was, so if you look at the WHO recommendations, if you look at that flow chart, where it says there is an indication to go to second line, which is heat-stable carbetocin, is if you cannot assure the quality of oxytocin, okay? So if you are at the point of care, you're the midwife, you want to give oxytocin, how will you know it's of good quality or not? Had it been you look at it and you can tell, do you know what I mean? Maybe they put something inside so that if it is denatured, the color will change, then you will know, isn't it? Unfortunately, there's no test like that. So that's a big problem. That's a big problem. So, or you ask the pharmacy, has the cold chain been maintained? All the pharmacists know is from the time they received it, isn't it? They don't know what happened before. So that's a big problem in terms of implementing that recommendation. Okay, enough said about that. Let's move on to the secondary analysis. So I know the table there is quite difficult to read, but I'll just give you the highlights. So the mean age of these women who died from postpartum hemorrhage, about 29, standard deviation 6 years. Most of the cases were from Rift Valley, Western and Coast regions. Kilifi County recorded the most postpartum hemorrhage deaths. Most of the women who died were multigravida. 40% of them were treated at county referral hospitals. 75% were seen by medical MOs. And only 26% were seen by specialists. 51% of these women actually had cesarean section, and 45% who had received blood transfusion had 3 or more units. We found a significant association significant association with the risk of receiving a prophylactic uterotonic for place of birth, being seen by medical doctor or specialist, or the mode of birth. Also, the amount of units of blood transfusion received. Now, let's look at the compliance with the standard. So, of the standards that we decided to audit for postpartum hemorrhage, 8 of them, the standards were only met for 50% of the women that died, in most cases. And those standards that were most frequently met were assessment within 30 minutes, administration of intravenous fluids, and administration of blood transfusion when indicated. Now, these are just proxy measures of quality. Whether it was done correctly or not, I mean, we can go to town and look at all of those individual cases. The least met standard was active involvement of a senior medical professional in the management of a patient. So, if you have an obstetric hemorrhage, you need to get senior people involved, because I mean, you have massive hemorrhage, 40% of blood volume lost. It's just a matter of time, isn't it? 2-3 hours, game is over. So you need senior people, people to think quickly, what can be done to make a difference. So discussion, so strengths and limitations. So this was a very large database with very reliable data. So multiple levels of sort of data cleaning, quality assurance of the data. But the limitation is that this is a descriptive study, and as such, at best we can come up with hypotheses for further investigation. The primary data we had, was dependent. It depends on the quality of the data that you extract, isn't it? And we've talked about data quality earlier on, and then we could only sort of report associations. The standard-based audit analysis could have been more powerful if all the women that were managed for obstetric hemorrhage were included, irrespective of outcome. Then we can calculate odds ratios. But that was not possible. This was just purely secondary data analysis. If you had the funds and the time, of course, that would be a better way to go about it. So standard-based audits is quite a powerful tool that can be used for quality assurance at healthcare facility level. In places like England, I mean, it is just standard and routine to do audits. Junior doctors have to do audits every time. It's a good way for quality improvement. So the challenges I mentioned, regarding what other stakeholders in other countries felt will be they would experience in implementing the new WHO PPH guidelines and recommendations, maybe similar to Kenya. I mean, I'm happy to hear what you think from your experience. And so probably this gives us an opportunity for some mitigation measures. So in conclusion, there's a need for improved quality of care to minimize the risk of mortality from postpartum hemorrhage. The updated clinical guidelines combined with focused health system interventions. So we have to look at procurement, supply of quality, good quality uterotonics will likely contribute to the reduction of this morbidity and mortality from postpartum hemorrhage. Addressing associated factors with receiving that are linked with receiving prophylactic uterotonics may also improve outcomes. Also, we need interventions to improve data quality. So I thought when we're having a discussion about digitalization, somebody was going to talk about maybe electronic medical records, for example, because that's one way. You know, you get everything immediately when it's put in. You know, it's there. You know, you can retrieve it, and then also, you know, the recommendation will be that standard-based audits should be routine in our health facilities. It gives us a good opportunity to gauge implementation of several guidelines, not just the primary postpartum hemorrhage. So thank you for listening. Acknowledgement to all our donors, partners, funders, and the LSTM team. Thank you.
Thank you. Let's appreciate this presentation. I know we've not been appreciating the others, but at one point we'll appreciate all of them. So a good clap for Professor. Thank you for the presentation. And as we prepare for the next presentation, this next session, that is session 5 by Pamela. Yes, come along, prepare. So maybe I should just ask Professor about the SBA and what we do as near-miss audits that most of the counties are able to do it. Yeah? I get the opportunity to ask because I have the microphone. So as Pamela prepares, so the SBA, standard-based audits and near-miss audits, nearly the same thing. So if we are able to do the near-miss plus, and then we do that maybe cross-tabulation of the near-miss due to severe PPH and those who succumbed and those who missed to succumb, or those who survived, we can be able to move the analysis to the next level.
Yeah, let me, so, I mean, there's slightly two different things for different purposes, but can be complementary. So, so because a woman had PPH and was treated in this facility and she did not die, does not mean that what was done was correct. But maybe you just missed the bullet. So you missed the bullet by a mile. As you missed the bullet, it passed your ear and nicked it. That's a near miss. So by all means, those ones who got an injury when the bullet passed, you can put all of them aside and look clearly. But then every other person who received treatment, was it accurate? It was an opportunity for improvement to say, okay, you know what? Yeah, we got away. It looked fine. But of the 10 standards, you know, we're only hitting 5. You know, so we don't want to just have any risk or whatsoever. So periodically, you can just take, okay, all the cases of PPH for the last 3 months and assign somebody. These are the Kenyan standards. Audit from those case notes to see. And it's also an opportunity for you to say, oh, when I did the audit, it was so difficult to find these things. Then you say, okay, look, guys, our recording and documentation is poor. It's also an opportunity to improve that, you know, and to have a discussion to say as a team, this is how we're doing, this is what we can do better. So both of them are useful. And it's just to manage it in such a way that it doesn't look like a burden. It's not the same person leading everything. Give everybody some task to do, and then, you know, share the result and discuss the result as a team.
Okay. Yeah. Thank you for your answer. Is this on? Okay, Pamela.
Okay, so thank you so much for those discussions. The session is on confidential inquiry into maternal deaths for maternal deaths that occurred between the period 2015 2015 and 2018. I know we've been talking a lot about 2014 report, but I think it's now time to look at subsequent years, what has been happening in terms of the data that we have. So that's the outline of my presentation, looking at the background, aims and objectives of the CMD process, methodology, key findings, discussion and conclusion. So CMD, confidential inquiry into maternal deaths, I think it's something that we've been talking about from day one, from yesterday. And the key thing to note here is the systematic, multidisciplinary and anonymous investigation of all or a representative sample. So if you're doing a CMD, you can decide to do an inquiry of or review of all the deaths that have occurred in the country, or you can take a representative sample. And that can either be national or regional. And it's aimed at identifying the numbers of women who have died, the underlying causes of death for those women, and also identify some of the avoidable remedial factors associated with each of the deaths. So the confidential inquiry into maternal death system in Kenya began in 2015, and it has largely been informed by learning experiences from the UK and the Republic of South Africa, and with technical assistance and funding from the UK aid. So we believe that the system complements other existing audit and feedback mechanisms that are already in existence, such as the facility-based maternal and prenatal death reviews. Then we understand that the UK has the longest surveillance CMD program, having been established in 1952, and has been used as a global standard for the adoption of the methodology. So if we look at 1952, as we started when? 2015, we still have a long way to go. Yeah, so we shouldn't be discouraged. We'll get there somehow. Then aims and objective of the CMD process. The overall aim of this process is, of course, as being part of the quality of care approach mechanism, is to reduce morbidity and mortality during pregnancy and childbirth, and also just be a tool for assessing and improving the quality of care at the facility level. Then specific objectives is when we are conducting the CMD is to determine the underlying cause of death, because we are interested in finding out why did these women die, what are the quality of what's the quality of care that was received at the point of need, and then identify factors associated with the poor quality of care and make recommendations for improvement. Methodology. The methodology has generally evolved over time since we started in 2015. We started with the paper-based reviews. So we had a form, an assessor's form, which we were reviewing, extracting information from the files onto the assessor's form, and then from there we did the usual, the entering of that data into the SPSS and analyzing the information. But I think we've now gone digital. So we have the assessor's form, but it is linked to it is in an electronic form, and we are able to extract the data electronically and have the information easier for processing. And then the most important thing is that we use the WHO ICD-10 M classification. This is what we started with in 2015. So the form that we have is structured around the ICD-10. But I understand that we have moved to ICD-11. Is it ICD? Do we have 12 or we just have 11? What? Oh, just 11, yeah. Then, of course, we use the 3 delays model in determining the factors associated with each of these deaths. So that's an overview of the whole process. I might not go into the details of each of the boxes there, but We generally use the information that is within the Kenya Health Information System to get the numbers of women who have died from each of the facilities. And then we use that information to go out and get the files retrieved, have those copies, have the files copies, and we receive them at the Secretariat, do an anonymization. Anonymization just implies that we are kind of blocking out any identifier, the names of the patient, the facility where the patient was seen, the county where this file is coming from. But of course, we leave some other information like the level of the facility. We kind of remove information about the names of the healthcare providers who saw these women, but we leave in the information about the cadre because that is also relevant. Then after that, we give each file a unique number so that we can trace it back, and then have the regional assessors workshop, which are multidisciplinary, to review the files using the electronic assessors form that is launched on the ODK platform. And then we do the regular cleaning up of the data, analyzing and producing the report. So maternal death file challenges, these are just some of the things that, some of the challenges we face when we are doing these assessors workshops. As you can see on the picture on your right, on your left, is saying that one of the days we were doing a recap, and there was the issue of date of death, documentation of death of occurrence. So we were looking at information, we were looking at the recap and seeing, okay, poor documentation was one of the things that was coming out from the assessors, and insufficient, linking to insufficient information. And then there was documentation from referral facility. If you are referring this client to the next facility, the receiving facility does not have information about this referral, does not have the details of this referral. So you just receive a patient without key information that you need. So that was something that comes out. And then ANC booklets. Most of our information is in the ANC booklet. It's not in the file. So missing documentation and missing files is also an issue. As I said, we get the numbers of the files of women who have died from the HMIS to know that, okay, this county we're expecting maybe 20 maternal deaths, but when you visit the facilities, you might get 10, if you're lucky 15, yeah, because the rest of the files are missing. So I'll just talk about some of the key results, selected key results from this data, 2015 to 2018. So in total, we were expecting 4,295 maternal death files reported through the Kenya Health Information System to have occurred during this 4-year period, but we got 2361, which is 55% of the files. And majority of the files were retrieved from the county referral hospitals. The mean age of the women who died or who we had access to the files was 28.3. The youngest 13 years, the oldest 51, and below 20 years we had close to 10% of the women. So pregnancy status at the time of death, majority of the women had delivered. Actually, they had term pregnancies, gestation age 28 weeks or more. We had a significant proportion of the women, 16%, who died undelivered. And we have also some information about about women treated for abortion, less than 28 weeks. Mode of delivery, so the two modes of delivery, normal delivery and cesarean section. But why we put there this slide is that we were looking at, we were seeing a trend in terms of normal vaginal delivery between 2015 and 2017. You can see there's a reduction from 53.4 to 42%. But if you look at cesarean section, it's just kind of increasing from 42.4% to 52.6%. So, although there's been a reduction in when we come to 2018. Type of cesarean section, emergency and elective. Highest cadre of provider during care. So this question, the assessors was to look at the file and see from the time this woman was admitted to the time the woman passed away, who is the highest cadre of provider recorded in the file. So medical officers were kind of the highest, and you can see a slight increase, 66.4 and 68.7. But you can see from 2015 to 2017 a slight reduction among the medical officers, although a jump in 2018. And then obstetricians, 2015 to slight increase, and then a reduction to 2018. Yeah. Then we also looked at medical doctor and specialist review. So this was just a general question where you're asking, we're looking at the data and trying to find out, was this woman reviewed by a medical doctor at any one time? Yeah. So it was either just a yes or a no answer question. So was the woman reviewed by a medical doctor? Yes. Was the woman reviewed by a specialist when a decision to be reviewed by a specialist was made? Yeah. So there's you can see the figure there. Reviewed by a medical doctor, slightly reducing. And then reviewed by a specialist, also slightly reducing. So this is just something for the thought, for debate, whether we are having a reduction in the number of healthcare providers in that cadre, or open for discussion. And then we also looked at the time interval between admission and medical doctor review and specialist review. So we were looking at, okay, for looking at the file, when can we say the woman was admitted, and looking at the times of admission and the times of medical officer review, what is the difference? What is the time range? So very good data there in 2018, 71%. Of the women being reviewed by a medical doctor within 30 minutes, yeah, of admission. And still, if you look at more than 121 minutes, that is still a significant amount of the significant proportion of women who are seen after 121 minutes is how many hours? 2 hours. Mathematics. 2 hours, yeah. So, and then likewise the specialist review, there's we can say good response in terms of the 2018 data that we are seeing, and a slight reduction in more than 2 hours, because if you look at specialist review from 60 to 20, if you have to look at more than 2 hours. Then type of anesthesia, majority of the women, general anesthesia and spinal anesthesia is also gaining ground at the facility level. Then a trend in underlying cause of death between 2015 and 2018. As you can see, the red there is describing the obstetric hemorrhage, high above, then followed by hypertensive disorders, followed by pregnancy with abortive outcomes, and then followed by pregnancy, other obstetric complications, and then pregnancy-related infection, kind of balancing there. Then period of postpartum death. So we've seen majority of the women have delivered when they die, but now we look at after delivery, what is the time frame? Close to over 60%, 61% of the women dying within 24 hours. So if we can take care of these women within their first 24 hours when they give birth, just ensure that we have good quality service available for these women within this time frame, then we'll be able to see some changes in terms of reduction of maternal mortality. And then we also look at 48 hours and 2 weeks and see what interventions can we put at the different time frames in terms of reducing the maternal mortality. Then condition of women on admission between 2015 and 2018. Initially, when we decided to include this question in the assessment, based on the recommendations from the stakeholders who looked at the report for 2014, they said there was a comment that majority of these women are coming to the facility when it is too late. Yeah. So we said, okay, let's look at the condition of these women as they come in. So we see 48.8% are admitted in a stable condition. Yeah, of course we have others who are admitted in unstable and unconscious condition. Then we also looked at contributing conditions. These are medical conditions that may have contributed to or may be associated with a maternal death. They may predispose women to death either as a pre-existing condition or a risk factor. So we looked at the top 5, which is anemia, HIV, cardiac disease, malaria, and tuberculosis. So we had a long list, but a long list of including nutrition. We had a long list, but this came out as the top 5. So anemia, HIV, cardiac disease, malaria, and tuberculosis. So we can start seeing whether we can put a story on the data, because you've said majority of the women are dying due to postpartum hemorrhage within 24 hours. Pre-existing condition could be anemia. And then still looking at the contributory conditions trend, you can still see anemia is still among the topmost. Associated factors are basically non-medical factors putting women at risk of maternal death, developed using the 3 delays model. And we have the factors are categorized into 4: administrative, health worker, patient, family factors, and community. But for this presentation, I just look at the 2, administrative and health worker factors. Health worker factors, as you can see there, delay in starting treatment. We have an aspect of inadequate clinical skills. We have inadequate monitoring, incomplete assessment, as some of the health worker related factors. And maybe some of these things can be tied together with what has been presented before, what was presented by Dr. Nelly in her presentation. Administrative factors, we're looking at aspects of infrastructure. We have unavailability of skilled staff. We have lack of blood transfusion services, some aspects of lack of equipment, lack of lab facilities, transport problems between health facilities, and communication problems. Communication problems could be between providers and also between health facilities. So what are some of the discussion points that we need to consider as we move forward in addressing issues of maternal health? So we need to know that obstetric hemorrhage remains a major underlying cause of maternal death, and you can see a trend across all the years. And majority of these deaths are occurring within 24 hours postpartum. Anemia is a major contributing condition to maternal deaths. We see a decrease in medical officers and specialists review. Don't know whether that means anything. But an increase in women reviewed by medical officers and specialists within 30 minutes of admission. And then close to half of mothers entered the health system in a stable condition. And health worker and administrative factors remain still key in as factors associated to maternal deaths. So we look at some of the 2 case studies where CMD has been done in Malaysia and South Africa since 1991 for Malaysia, and the process is driven by the Director General for Health. The CMD report provides an evidence base for budgetary allocation to the Ministry of Health. And in fact, in one of the case studies, in that case study, they were saying they don't have an issue of a budget for CMD. I mean, the issue of a budget for CMD does not arise because it's a priority and there's allocation for that, and it is driven from that high-level office. South Africa, since 1998, is ongoing under the National Commission for Confidential Inquiry into Maternal Deaths. So those are some of the 2 key things, countries that we can learn from. Then from the case study, you can also just see some of the factors. They've documented factors ensuring success of CMD in Malaysia, and one of the first factor indicated there is political will and top management commitment. Then, of course, multi-sector approach, commitment to organization and management with skills upgrading of health personnel, and investing in facilities and manpower for health, and then making special efforts for maternal health and reduction of maternal mortality, including maternal death audit at local, state, and national level. So just having the audits in place. But also an important lesson to learn has been that CMD, one important lesson that has been documented by the CMD Malaysia case studies, that CMD must remain confidential and non-punitive system. Yeah. So, and this has to be across board, because sometimes we would say health workers, we know it's CMD is confidential, but in this country we have seen some people being victimized, especially at county leadership level. Then the confidential inquiry into maternal deaths in South Africa. Some of the benefits of the CMD process in South Africa include improved reporting, review of treatment protocols for PPH and management of cesarean section, especially after deaths from bleeding associated with cesarean section increased from 26.2% in 2010 to 35% in 2012. So initiation of steps in managing obstetric hemorrhage in pre-service training program, and a significant decrease in maternal mortality due to HIV. So they've seen a significant decrease in maternal mortality due to HIV. This was after the CMD report revealed that maternal deaths due to complications of antiretroviral therapy tripled, and hence the treatment was modified. So just using the results of the CMD to make to modify a treatment guideline. So in conclusion, we need to focus on the period or intervention where there can be a major impact, because we know resources are limited, so we need to be very smart with the interventions that we have, and target the area where we feel or where there is evidence that is where we'll get a bigger impact. Then early identification and treatment of women at risk. This has been said here and in other forums. Then CMD process has a role to play, especially in the identification of health system challenges and recommending solutions. So the CMD process also gives recommendations at high level and strategic, because it is something that is not done on an annual basis, something that comes periodically. So it can give recommendations at a higher level. And then CMD process can work with good political will and with adequate budget allocation. Yeah, so that's the end of my presentation, and thank you for our partners and collaborators and my LSTM team.
Martin, I cannot even see the cost. Okay, so just bear with us. So last stretch before the questions and then lunch.
Could you try again?
Sorry. Yes, so I'm going to quickly run through this crazy idea I have, and happy to take questions on some of the details because some parts there's a bit of detail that I may not be able to explain fully given the time. So this is the outline I'm going to use. I'm going to talk about the burden of maternal deaths very quickly, learning from maternal deaths, how to make MPDSR process more useful, and then I will talk about accountability, how we can improve accountability as a key to improving the quality of care and reducing the deaths that we're currently seeing. So I'm going to introduce a concept, a framework which I call the Global MDSR Accountability Framework, and then I'm going to discuss how it can be used. So we already talked about this, still very alarming numbers when it comes to maternal deaths globally, especially in sub-Saharan Africa. Just to go down, some history. So, in 2004, the Beyond the Numbers manual was launched from the WHO, and then maternal death reviews were promoted, very actively. And in fact, Kenya was one of the countries where all of this was really pioneered. By 2012, the WHO released technical guidance for maternal death surveillance and response. And by 2021, they produced a report which suggested that, implementation was lagging behind, and they produced further guidelines, now introducing, guidelines about, including perinatal deaths to the maternal death surveillance and response. So quick reminder of some of the things we've been talking about. The MPDSR surveillance circle and response. So when we did the maternal death reviews only, one of the things that, one of the big concerns was that we were not seeing any change in terms of improvements in quality of care or reduction in maternal deaths. And there are several components which we need to look at in this circle. So first, we need to identify the maternal deaths. We need to get all the information, related to that death, which may come from multiple sources. We need to be able to review them objectively so that whatever we find, it will make meaning if we implement the recommendations from those findings. If the quality of the reviews is poor, then your recommendations is not going to make a difference, okay? So if all the reviews come out to say, well, the women are coming late to the facility, they need more health education, isn't it? We tried our best. Under the circumstances, we absolutely did our best. There's nothing more we can do to improve. That's not going to make a difference. So, but the best way to so what happened in Kenya? So you saw the difference from Pamela's presentation. The number of deaths that were reported through the Kenya health information system, and the actual number of records that you could retrieve physically from the healthcare facilities, nearly 50%, isn't it? So it tells you something. Are those records disappearing into thin air? It's something funny going on, which should not be the case. So you need those things to review. When you review, you need to be able to produce reports. And then, with those reviews, you make plans for quality improvement, and then you measure to what extent those recommendations for improvements are being implemented. So this is quite important if we're going to improve the situation. So I reviewed the literature to look at the challenges to implementing MPDSR, and, I used this framework. One, what are the challenges with identifying and notifying deaths, reviewing maternal deaths, analyzing and making recommendations, and responding and, monitoring the response. So this is really detailed. The next few slides, I'm not going to mention everything. Can somebody shut the door, please? So in terms of notification, I think when this was introduced in many countries, there was confusion with healthcare workers, what exactly their role was, the fear of getting involved and the legal ramifications, and then, this issue of blaming and shaming, which Onesmus talked about. And, there are several interventions to help, address this. Good leadership of these committees, training and orientation, a lot of those things that we're doing in Kenya. And also, if you have some sort of legislation, to protect, you want a real, to separate, the system of reviewing deaths to improve quality of care, and then, a system where you identified, malpractice and you deal with it. So we're not saying MPDSR should stop you from identifying malpractice and dealing with it. There should be two separate processes. So information you get through the maternal death review process should not end up in the tribunal, in the medical council, or in the court of law. They're two separate processes. Otherwise, nobody will want to get involved, and the case notes will continue disappearing, isn't it? So these are some of the issues. So when it comes to reviewing of maternal deaths, the question is the validity of the reviews. How credible are those reviews done at facility level? If people are so concerned that they might get into trouble, then the reviews will always be skewed towards external factors and not internal looking in terms of what can we do to avoid the next death. So that's a problem. But then in the best, in one of the biggest cluster randomized control trial on the effectiveness of MPDSR, what they found out was if you use an external facilitator in those meetings, so somebody from another facility, attends this facility's maternal death reviews periodically. This person is from outside, is objective. It may help keep them on track to say, oh, wait a minute, I think we have not looked at this, we have not looked at that. What does that mean? This action is for what, by whom, by when? So just an external eye seems to help, increase objectivity and, of course, strong leadership of those review committees. In terms of analyzing and making recommendations, so again, if you have bad quality review, it affects the integrity of recommendations, isn't it? So again, use of external facilitators, training and supervision as mitigating factors. Response and monitor, so lack of implementation of actions, is a problem. There are limited, very good studies on effectiveness of MPDSR. But MPDSR is just a thing, isn't it? We do it, we fill the forms, we upload, we produce national reports, and then we ask the question, so what? What has changed? How many lives have you saved? That's a big question. But, I think the problems start downstream. So there's limited international agreed framework for reporting, monitoring recommendations, so this is not available. So we can develop an accountability framework, for example, to help address this. We can strengthen committees' decision-making at all levels. We can, we can look at, the use of external facilitators to increase validity and all of that. So a lot of people miss this in that WHO MPDSR guidance of 2012. It stated 7 clear principles for an effective response. There's 7 of them. One, you need to start with the avoidable factors and which you identify during that review process. You need to use evidence-based approaches. You need to prioritize actions based on prevalence, feasibility of resources, health system readiness. You need to establish timelines for implementation of actions. So immediate, short-term, medium-term, and long-term. 5, decide how to monitor progress, effectiveness, and impact. 6, integrate recommendations into annual health plans and health system packages. And then 7, monitor to ensure recommendations are being implemented. So these are the 7 principles of a response. And I'll tell you how I propose this can be used effectively to guide accountability. So let's go to some of the academic definitions just for purpose of argument. So what's accountability? So accountability exists when an individual or a body and the performance of tasks or functions by that individual or body are subject to another's oversight, direction, or request, that they provide information and justification for their action. So that is what accountability is. And in many setups, we feel uncomfortable about accountability. We feel quite uncomfortable about it when you start asking questions, when you put names to actions and you ask questions. By this time, it is not done. Why? People don't like that, and change is quite difficult. So there are different categories of accountability. 1 is professional and performance. 2, political, democratic, which includes social accountability. 3, financial accountability. So this was by some very good work by Brekanoff and colleagues. So an accountability mechanism or process is a formalized process that aims to ensure accountability. Accountability mechanisms used to achieve professional performance include things like accreditation and certification, benchmarking, clinical audit, management audit, and performance-based financing. An example of an accountability measurement tool is scorecards. Does anybody know about scorecards? Yeah, so scorecards is an accountability measurement tool. So several mechanisms may operate successfully, for accountability, and these have to be used in tandem. So there are very few health accountability mechanisms in low and middle income countries, and where they exist, they are weak and poorly implemented. It is difficult to assess accountability in maternal and newborn, in maternal and perinatal death reviews, because there are no robust frameworks to do this. So this is where I've come up with this crazy idea. So based on this accountability framework, which I'm proposing, we can have a score of 0 to 4. So the higher the accountability score, then the more reliable the MPDSR report is for making strong decisions around policy and quality of care. And, the higher the score, the higher the level of accountability. And then, each of these overall accountability score is a sum of several compliance with standards that are linked to those 7 principles of those response. Okay? So what I've done is to take the 7 principles and break them down into 14 different actions linked to each one of those 7 principles. And then if you take, for example, a report, an MPDSR report, and you score it against those standards, you should come up with an accountability score. The higher the accountability score, the more objective the report, the more useful it is, the more trustworthy it is, the more valid it is, and then you can use it to make actions that can make a difference. So the next few slides I just cut from the table, but essentially, I don't expect you to read it, but just to explain. So you have the overall score 1 to 4 there, and what the score means. So for example, 0 indicates that important aspects of the accountability framework standards are absent from the report. The report is incomplete, potentially unreliable for policy and decision making, and additionally it indicates a low level or no maternal newborn health accountability, whereas 4 indicates that the report exceeds the global MPDSR accountability framework standards, and it can be used with high degree of confidence by stakeholders and decision and policy makers, and it indicates a high degree of M&H accountability. So of those, if you have the total score, those reports that are scoring 12 to 14 are most likely to have a total score of 4. So, so you understand the line of thoughts there. So I'm not going to go through the details. So so for each one of those 7, which is from the first column here, I've broken them into different things that you want to look out for in a report that links to that. So 14 different things. So I'm not going to go into all this, but how did I test this thing, whether it's useful? So we reviewed, it's so difficult. It is incredibly difficult to find national MPDSR reports. They're not found in one place. You have to talk to many people to fish out version 1, version 2 from one place or the other, which is quite sad, because if we are learning from each other, it should be centralized. You can see what another country is doing to improve yours, but it's quite difficult. So we targeted, so 7 years after the technical guidance was published, we looked for all reports in English or French, got them translated and all of that. And then, we sort of scored them against that framework which I proposed. So there are 42 reports from 27 countries in Africa and Asia. 10 countries had more than 1 report. These were subnational, for example, in Nigeria, or national reports from different years. In case of Bangladesh, Burkina Faso, Eswatini, Malawi, Mozambique, Sierra Leone, and South Africa and Uganda. 9 were confidential inquiry into maternal deaths, 23 were MPDSR reports, and 10 were maternal mortality survey reports. The report from Kenya had the highest score of 8 out of 14. Even that was not perfect in any way. The most frequently reported GMOF standards were recommendations based on avoidable factors identified during the review, for 33 of those included. Then number 2 was a detailed methodology chapter was present. Number 3 was recommendations were based on analysis of available data. So these were the most frequently identified standards. Whereas the least frequently identified standards in those reports were a monitoring plan for implementing recommendations clearly presented. So this is when I talk about how people feel quite uncomfortable about accountability. So if you do a national report and you say these are the recommendations, you should say with confidence, this person is responsible for this report, for this recommendation completed by what time, and you put it out there publicly. You know, that's accountability. But you know, you can see people don't feel comfortable. A detailed plan to monitor effectiveness of recommendations, detailed plan to monitor impact of recommendations clearly presented, evidence of a monitoring report on the implementation of the recommendations from the last report. Okay, so if I do a report this year and I do another report next year. I mean, it begs the question, how much did you do? How did you progress the last time? But we just present the next one, we launch, we take pictures and everything, and then, you know, so that's not accountability. So you ask the question, and you should be upfront about it. Then evidence of effectiveness, impact, lessons learned, implementation from the last report. So 0, you know, this was not available in any one of those reports. So when you look at, you know, the global score 0 to 1, so most reports 38% were at 0, 29% were at 1, and then most of them were just at 2. There was no report that met the standards to be given a GMAP score of 3 or 4. So in most of the reports included recommendations based on analysis of data. The least reported ones I've mentioned. 2 of the least reported response principles were establishing a timeline and monitoring to ensure recommendations are being implemented. I think that if we can standardize the use of an accountability framework like this, and you have an independent body to provide accountability scores for each report, it will drive the standards up. No country wants to see their report 0, isn't it? If you are 0 now, next year you'll be aiming for 4. So it will drive accountability. And I think it can be used at different levels, institutional level, subnational level, at international level, okay? So very provoking discussion. And no surprising, you know, I'm struggling to get it published. People don't like this type of stuff, isn't it? So thanks a lot. I'm happy to hear your comments and recommendations.
Okay, thank you. Another round of applause for Professor. That's the best you can do. Makofi. Hey, at least we scored what? 8, Cynthia? Yeah. Eh? So we are doing something. We are doing something. So at this juncture, can we have few questions? Do we need to have the panelist here? Yeah. Mm-hmm. Few questions. We reduced to one each. One each, eh? Okay. A question for the first one was who? Oh, there were 2 presentations made by Professor Ame. So you remember the session 4 one? You remember session 4? It was about? Kabetocin. I like that. So any question for that session? Any question? Yes. For the session 4. The one for Kabetocin.
Okay. Yes, Prof, thanks. I think I just wanted to look at the one for Kabetocin, as everyone is saying, just to understand. One thing is, if tranexamic acid is recommended for PPH within the first 3 hours, I don't know if we've had any suggestions to have this among the signal functions at WHO level, to just reinforce its inclusion in to ensure that it is adhered to at your level? I think that's the question I had.
Francis, thank you, Francis, for the question. Any other? Yeah.
Okay, I think I got it that oxytocin is denatured when exposed to heat at a time. So I was just trying to imagine now that we may still need to use oxytocin for augmentation of labor. If it is denatured, does it affect that process of augmenting that labor also? And is there a possibility of putting like a VVM, like that, the ones we put on vaccines, so that it is we are able to know whether it has been exposed to heat and whether it can be used or it may not work?
Okay, I think, Professor, you should respond to the two questions.
So two very good questions. So Francis, in terms of the EMOC signal functions, so there's discussion to revise those ones now. I know they tried organizing a meeting, what date is this? Early this month, but I don't think it happened. I'm going to follow up to see with Dr. Alison Moran of WHO. So her department deals with this. So there've been a lot of concern that it's a bit out of date now. We need to refreshen it a bit. So I think this is a good suggestion. It's something that I can introduce to the discussions. Concerning the potency and the use of oxytocin, especially if we think it's denatured for augmentation, I think it's going to be similar, isn't it? So you find yourself using an increasing dose to have any contractions, even augmentation. But I mean, I think usually we are quite disciplined in terms of the dose we put in because we don't know whether it's working or not. And, so we're quite disciplined. So what will happen is that there will be more cases of failed induction and then a revert to cesarean section. That's the implication, essentially. Yes, so I think that's it's a near, maybe not exact Nobel Prize task now, is to find a test that you can determine the quality of oxytocin at the point of care. And if we can use all that knowledge from vaccine, for example, to be able to put this to do this, I mean, that would be great. But I mean, I may be quite cynical when I think about why some people will not invest to finding those kind of solutions if there are alternatives. I mean, the pharmaceuticals, I mean, they run the show in terms of all of these things, isn't it? So, I don't know. So I think somebody really needs to push for us to do that. So we still need oxytocin. We still need oxytocin. Even if you make carbetocin the same price as oxytocin, you still need something to augment labor, isn't it? So I think it's still a challenge. I mean, no ready answers for that from me.
Those two questions. The next one was for confidential inquiry. Wow, we have questions there. So we'll take the two questions. Confidential inquiry. Okay. After confidential inquiry, you'll ask. Okay.
Thank you. Dr. Pamela, that was really good. Thank you. Just wanted to find out, of the 61% who died within 24 hours, what is the split between public and private, if we have that data available? And additionally, how has the rollout of CMD impacted the reduction of maternal mortality? Do we have that kind of information, whether it's at facility level or at county level, even in a granular way? Thank you.
One more.
Thanks a lot, Prof. and Pamela. Now, mine could be alongside all those CMDs, but at whatever level. But first is to commend, yes, the great work that the team has done. The mention of the issue of the the deaths that were reviewed by the AMO or the specialist is double-edged, not a sword, so don't look at it. Because it only just shows that, yes, these deaths, because sometimes one can say that, okay, though they were reviewed by the AMO, or though they were reviewed by the specialist, but they still ended up dying. The question would be, which I think you alluded to in the earlier presentation that I joined when you're on the floor, or earlier on, is that how many of all the complications that occurred in the maternity, how many were reviewed and then ended up surviving were reviewed by the specialist, by the AMO? I think that end is a bit gray. Okay, we don't have that data, but it would be good maybe in another study one can look at it, that of all the mothers that were admitted in the house, in this facility or in the facilities, how many received the reviews by the medical officer? Because they're assuming, because this is just a proportion of those who died. Yeah, so whether they have increased, it could be just that you have higher numbers. We get just like the same say when we say that the cesarean sections have increased. It is not, probably the counties have more, there's better access, and therefore the numbers increased from 2% to 8%. But maybe because they have more access or better access. Two is there's recommendations that Pamela you made, which I don't know whether were in terms of during the conclusion we talk about regional anesthesia and qualified or more experienced health workers. I don't know whether they were based on the findings or they were just these general statements that are being made, because I don't know whether in this analysis there was any evidence to show that those who were under GA were the ones who died more, or was there any comparison so that we make such a recommendation, or is it just an addition from other sources of other resource materials or source information? And the same applies to the qualified staff. Thank you.
Thank you, Dr. Okoro. Let me introduce him. He's Dr. Okoro from UNFPA. He came late. So we have that opportunity to answer those questions.
Yeah, so the 61% who died within 24 hours, no, we have not separated. We have not disaggregated that data, that public-private, but we have the data, so we can do that and see whether there is any difference amongst the public and private and FBO, NGO. The rollout of CMD and the impact on reduction of maternal mortality, that's a big one. That's a big one. So this process we started in 2015 using 2014 files, and then we went to 2015, 2016, almost close to the same time, reviewing those files. And the reports between 2014 and 2015, 2016, the result was somehow similar. 2018 is when we disseminated the report for the 2014 file. You see, we've been working behind, so we are kind of behind. So we are hoping the data that we have for 2019, 2020, which we have not reviewed yet, maybe it will show something different. Because now people are more aware, people are also having discussions within the hospitals on maternal deaths, and then we feel that the blame game is kind of reduced a bit. In most of the facilities, people are more comfortable to talk about maternal deaths, and the reviews are ongoing. So we hope that will come out in the subsequent data that we have, but that is what we are hoping for. Yeah, so we actually don't have that data to say there's been an impact as such. Then the MO special, I think this was a comment done about the MO and specialist, how many the proportion of mothers who died the proportion of mothers, we presented the ones who died but were reviewed by either medical officer or specialist. But I think it's something we can do to look at mothers who were among the mothers who had complications in specific facilities, those who were reviewed by MO and specialists, and they survived. So looking at the differences between the two, among the ones who died and the ones who survived, but they were all reviewed by medical specialists, and they had complications. Yeah. So I think that is information that it's interesting information that we can look at. And then the recommendation was on regional anesthesia. I don't know whether that was my recommendation on regional anesthesia, but I think I also looked at that Dr. Nelly's study when she presented her case control study, where she looked at women who had cesarean section. I don't know whether you had come yet. Yeah, we had a previous presentation where Dr. Nelly Pato, she looked at, she did a case control study to look at women who had cesarean section, who died, and those who had cesarean section and survived in 2014 from KNH and I think KNH and Pumwani. So one of her conclusions was that the ones who had, there were some risk factors, and the ones who had underwent GA were more, the odds of them dying were more than the ones who did not have, because she did a case control study. So I think I had just referred to that study when I did the recommendation, the conclusion on my part. Yeah, I think maybe Charles, you want to add?
Thank you, Pamela. So just a few things. So most of the analysis you see in the confidential inquiry now, these are just descriptive analysis. You cannot make conclusions about causation. You cannot. At best you find an association, you set up a hypothesis, and then you plan to actually investigate. So the question, Dan, the research question will be, does the involvement of a medical doctor split by years of experience and training make any difference in the outcome? That's the question. So that's a separate research question. So now what you need to do is that you're going to take all the women who come for birth, and all of them, you classify them into reviewed by doctor, yes or no. If reviewed by doctor, level of experience, specialists, one group, MO more than 4 years, one group, MO 2 or 4, medical intern, if they reviewed, and then you look at the outcomes, and then you calculate the odds of death. And that will answer your question. So this, you cannot, from this data set, you cannot, any analysis you do now will be descriptive, but it's not going to solve that problem. But then, the beauty of this type of thing is that now we know that we need to answer this because of the controversies it brings. Everybody suddenly goes into defensive mode, isn't it? So then maybe we need to do it properly. Then you have really, some information that you can work on. But just this type of analysis will not. So ideally, if you have a well-functioning confidential inquiry into maternal deaths, from this analysis, you can come up with questions and additional studies that will be funded, and you go through, you continue. That's what they do in the UK. There are sub-studies that will go on, for a good reason. So well-funded, well-functional, that is what should be happening. Yeah. And then finally, a question about the cesarean section. So if you look at the Lancet series on cesarean section 2018, there was this thing about too many too soon, too few too late. So what that means is that we have a low threshold for doing cesarean sections. A lot of them may not be medically indicated, not be appropriate. We've not waited enough to give the woman a chance. There's nothing. Okay, I tell you now, just take 10 cases of cesarean sections from your facility or anywhere and look at the indication. I bet you 7 out of 10 is fetal distress. The remaining is lack of progress. What does that mean? Obstruction is just something, randomly, nobody knows what it means. So, so too many, we do too many. Then for those, then too few, too late. When you finally take a decision, you've taken the decision too late. There is a reason, but there's so many delays. anesthesia, theater, transport, no blood, then finally you do it, it's a bit too late. Perinatal outcome, maternal outcome. So I think the objective from Nelly's presentation is we should just have the right indication and do things at the right time, and then that will make things better. Now, one of Nelly's slides may have been confusing. She was comparing two different things, apples and pears, the way she presented. She was talking about population-based cesarean section rate and institutional cesarean section rate. Population-based cesarean section rate is always lower. Institution is higher. You cannot compare the CS rate in Kenyatta with the one they find out from the population-based survey. I mean, the difference is going to be really massive. So there are two different things. So population-based cesarean section rate above 10% does not lead to a decrease in perinatal and maternal mortality. That is the recommendation. That's the observation. It doesn't mean that Kenyatta should start to aim to come to 10%. That would be bad news, because they get all the very bad things. It has to be. So they just need to make sure that they're doing for the right reasons and on time. Thank you.
Who has learned like we collect Cecilia section rate in our KHIS. I don't know which. So the session 6. You remember section 6 was on? Session 6, I mean, accountability framework, and that's for Professor Ame. Any questions? Introduce yourself.
Good afternoon, everyone, and I'll try to keep it very brief on accountability framework. I think as Prof was making the presentation, I kept thinking around how to involve the communities that are concerned, either through CBOs or other more formal channels, to be part of the accountability framework in a meaningful way. And I guess the question then is, how do we invest in such structures so that you have the voice of women really championing accountability for MPDSR. And then the second one, still around accountability, was having external facilitators. And I know this is more on the methodology for CEMD, but I see it a lot as part of the accountability framework, where you have external facilitators who are also mostly health workers who are looking at files from a health institution. So there's a certain language and a certain expectation. And I mean, this is a pattern that most of the external facilitators are used to, and how this colors them or how it biases them in terms of giving objective reviews. And I think I've had a little experience as an external facilitator where you go into a facility, but they push back on you. They're always like, it's because you're not practicing anymore. It's because you're at national level. That's why you have these glaring eyes. And there's still a lot of shielding each other and trying not to have the blame game. And so in all that, the question is, how do we have effective and truly objective support from external facilitators to strengthen that accountability framework? Thanks.
Okay, thank you, Dr. Ngoi. One more question for Professor. One more question for Professor. I want to give most.
Yeah. Okay, so thank you very much for the presentations. And I think for me, in terms of MPDSR, I think one of the questions that keeps running through my mind is in terms of involvement of other sectors, even in this accountability mechanism. Like if we look at the leading causes of MPDSR, anemia is a leading cause. But nutrition, okay, in the whole, I think, discussion, we've not had discussions around what's happening with nutrition. Are we linking, especially when mothers come for ANC, and do we have any aspects that have been covered in the current program, or could they be considered for future programs, so that we then look at what multi-sectoral collaborations do we have in this response? Because when Prof, you were presenting, I think in one of the slides you said since 2014 up to 2021, we still have pending response. And that was the last line always, pending response, pending response. So how can we strengthen that to get meaningful results? Thank you.
Okay. Thank you, Esther, for your question.
Okay. Thank you. My question goes to Prof. And it was about the heat-stable carbetocin. And if I want a clarification, if I heard you well, you said that it's not used to augment but it's used for PPH prevention. Yes. Yeah, that's what I wanted a clarification on. And I think you have answered, because I was to ask if then it can be used for augmentation of labor, then we should do with the one that is bringing problems because of the temperatures and everything. Thank you.
Thank you so much, Prof. I just want to dwell on the last part. I think this accountability framework for me looks marvelous, and I would wish that it's adopted for national level and even to the counties. I think mine is linked to Dr. Wangui's question on, now from your findings, who would you propose to be members of this accountability team, especially at national and county level, in your view? Thank you.
Okay. Sorry.
Okay, thank you. So thank you. All very good questions. Let me start with a question from my sister Wangui. So how can we get the voice of women to help drive accountability? So I think if you had credible reports that have been scored and they have open access, and those women groups and all of that can look at those things and use that to demand quality and to ask questions, because they can say, you know what, this is not good quality, it doesn't work, you need to do better. Well, okay, yes, it's good quality. You now have stated clearly what you are going to do by when, but you have not done it. And they know exactly who they're asking the question. That is accountability. That's a mechanism that works. So I think it's if you put that tool in place, then that resource is available for people to ask questions. Then the use of external facilitators. So I hear you clearly, and medical practice is such a tribal thing, isn't it? We're all in different tribes, and I'm a midwife, I am a doctor, I am a specialist, I'm a clinical officer, and everybody is guarding their own. Seriously, you've purchased ultrasound machines, and now people are angling for, I'm the only one allowed to touch it and use it. Whereas all you're doing is basic ultrasound, for goodness sake. You're not doing anything fancy. Anybody can do basic ultrasound. Is there, where's the baby facing? Is the heart there or not, or whatever, basic stuff. Those machines, there's probably nobody, using those machines to full capacity. When you go talk about the guys doing fetal medicine, and then they're doing all sorts of crazy stuff, now we're talking. So why are people being so protective about those type of things? So back to the question, I digress and I apologize. So in terms of external facilitation, so if you get a healthcare worker from another facility going to attend the MPDSR meetings in another facility periodically, they're coming from outside, almost similar setting, similar level of experience. Maybe clinically they have the experience as well to work with the team to link some of the recommendations to clinical actions and training and things like that. So in that cluster randomized control trial that I talked about, the main thing, apart from the objective reviews, was also linking the recommendation to training, and then those external facilitators helping them through some of those actions. That was what made a difference. And that cluster randomized control was so good because the outcome measure was actually maternal mortality, maternal deaths, and it showed a reduction. So that was really good. So that's what I will I'll recommend in terms of that. But as usual, when we talk about these things, we need to look at the practicalities. You're talking about external people coming to join one facility and all of those things. Who's going to pay their transport? So there are those other questions which need to be, talked about. Then in terms of multi-sectoral collaboration, so recommendations and who is going to take the lead and making sure that recommendations are implemented, or some of the recommendations we can look into them in greater detail. So women are dying from PPH. So there are many things. If a woman comes into labor with a low HB for any reason, malaria, nutrition, chronic illness or whatever, that is something that needs to be addressed, isn't it? It's a different thing. She comes in normal HB, she bleeds, and there is no blood. They're all different things. So we need to look at everything. You cannot exclude anything. So for my team and the work we do in Kenya, so we have a separate program on antenatal, postnatal care funded through Global Fund, and we're implementing this in the same facilities we're strengthening with EMOC. So it's a whole continuum of care. So nutrition, they do all the nutrition things and all those type of things, postpartum IUD and all those. So, everything is covered. It's interesting. Tells you it's close to lunch. I can't even read my own handwriting. Esther talked about pending response. Okay, I think I probably have talked about it. Then heat stable carbetocin. Yes, so prevention only. Not for use for augmentation. In fact, there was a joint statement released maybe about 3 months ago by FIGO and all the partners, really to caution about the augmentation thing. So it has not been tested for use for augmentation. There are problems if used that way. And then thanks for your comment, Francis, about the accountability framework. So the question is accountability team and all of that. So like I said, just talking about the principles and the mechanism and all of that, somebody completely independent should be reviewing those outputs that are compiled as reports and putting a score on them. And then other people should be asking the questions based on those reports. It may be somebody in leadership in the Ministry of Health at county level and all of those things. But then this will make everybody sit up at different levels. Nobody wants their score to be the same time after time. If I was the leader at some level, I would say, this is now a joke. We are not seeing no improvement. Okay? So all we need to do, if this system is adopted, there's an independent group that is doing it. So for example, just an example, if in Kenya you say, okay, say the Ministry of Health says, okay, we give this contract for independent review and scoring of all reports to, just for example, University of Nairobi for the next 4 years. Their TOR is to review all these reports that come out from the counties and, against this framework and score them independently and put them in a central place. Anybody can check, anybody can see. So that's how it will now, snowball to improving actions. So for now, it is all conceptual, I don't know when this will ever, anybody will take me seriously, but that's the only way. Otherwise, I think in 10, 15 years' time, we are still doing MPDSR. We may even add another letter to the thing. Nothing is happening. Nothing is going to happen because there's nothing driving us to want to make a difference. Okay. So I think we may be at the risk of missing lunch, but.
Okay, Pamela, you want to say something? Not much. Maybe I can just reiterate the comments that were made yesterday by one of our guests, the governor of Vihiga, when he said that two most important things that are needed if you want to bring about change within your area: top leadership support, commitment and political will at the leadership level, and 2, legal framework. Framework for anything that we do. I think that has also been a challenge within the MPDSR process. I remember when Dr. Wangwe and I were still working closely together before she ran away. We tried to have the National MPDSR Committee gazetted, because the committee members felt they need some legal understanding, legal identification, on their roles and responsibilities. So we tried to have that committee gazetted officially, but we hit a snag somewhere in the Ministry of Health legal office because we were being asked, you want this committee to be gazetted, where is the legal reference point that we need to refer to as we gazette this committee? So we hit a snag there. And something that has been done legally, it goes, resources follow it, So the good political will and also a strong legal framework. Thanks.
Okay, thank you, Pamela. I don't know what advice you'll give us now that you're exiting the arena, maybe not totally on that legal framework. If you hit a snag and still it is being recommended, what do we do? So with that homework for Pamela. Okay, we'll still explore that. I think eventually we'll have something to make us do better. And for Professor, we've added an end to the MPDSR, maybe for Kenya, because we want to have the perinatal and neonatal audits in the same. So that is under discussion. So we are adding. We don't have to wait for 16 years. So with that, we're going to give everyone who presented, anyone who asked questions, all that participants will give ourselves 4 factorials. And we begin now. Tuanze. 1, 2, 3, 4. 1, 2, 3. 1, 2, 1. Good appetite.